Good afternoon, and welcome to the 2026 Prevent Cancer Advocacy Workshop. I'm Jennifer Nyangota, Vice President of Development and Marketing at the Prevent Cancer Foundation. Next slide. Thank you for being here today as we bring together voices and expertise from patient advocates, healthcare providers, survivors, patient navigators, and others who are committed to risk reduction and screening. Before we jump in, I'd like to thank our sponsors whose generous support enables us to host this workshop. Thank you to Genentech, AstraZeneca, Eisai, Quest Diagnostics, and Abbott. Thank you also to our Prevent Cancer staff who work together to bring this event to fruition. Thank you to our CEO, Jody Hoyos, our Senior Director of Policy and Advocacy, Caitlin Kubler, and our Communications and Development team members. And last but not least, thank you to our speakers for lending your time, your knowledge, and your passion for our mission. Our theme today is building trust, moving patients from skepticism to screening. And I don't think it's a surprise to anyone in this room that we chose this theme at this time. You've probably noticed, maybe in your conversations with neighbors, maybe in your social media feeds or on the news, that mistrust in the healthcare system is a pervasive problem, and it seems to be getting worse by the day. Next slide. In the Prevent Cancer Foundation's 2026 Early Detection Survey, 73% of U.S. adults reported being behind on one or more of their routine cancer screenings. That's an increase of 4% from 2025. We're moving in the wrong direction. Next slide. And while there were other top factors at play here, including not knowing they needed to be screened, not thinking they needed to be screened because they didn't have a family history of cancer, or worries about being able to afford the cost, there was also evidence of growing mistrust. Next slide. Nearly 1 in 5 adults who were behind on their screening cited skepticism in the healthcare system as the reason, jumping 5 percentage points from 2025. Next slide. Among these respondents, nearly half said that their mistrust stems from a belief that the healthcare system prioritizes profit over patient care. Others pointed to past negative experiences, including unclear or conflicting information. This lack of trust is not hypothetical, and it's not a social media trend. It's a barrier. It's a barrier keeping real people from getting the health care that they need. The good news is we can do something about it. And the people in this room, the people on this webinar, are the doers. We asked people directly what would help increase their trust in cancer screening. And here's what they told us. Next slide. They are looking for clear, consistent, and transparent communication from providers. They're looking for affordable and predictable costs. They're also looking for more time and attention from healthcare providers and more information about the benefits and potential risks of cancer screenings. Today, we'll dive into the issues at hand so we can give people what they need to stay ahead of cancer. We're looking forward to thoughtful conversations so we can bridge these barriers and move patients from skepticism to screening. Next slide. To get us started, it is my pleasure to introduce Caitlin Kubler. Caitlin is our Senior Director of Policy and Advocacy, and she works tirelessly with a network of peer groups and partners to engender support for cancer prevention and screening. Please welcome your facilitator, Caitlin Kubler.
Thank you, Jennifer, for that warm introduction. Before we begin, just a quick housekeeping item. We will have time after each presentation for questions. Please use the more 3 dots at the bottom of the screen, the Q&A box, and submit a question. And if you do have any technical difficulties, you can use the chat box and our vendor will do our best to assist you. With that, it is my pleasure to introduce our first speaker, who is Dr. Jean Asius. Dr. Asius is President and CEO of CHC, Creating Healthier Communities. Dr. Asius has dedicated his career to breaking down barriers to health, expanding access and opportunity, and building cross-sector collaborations that empower communities to thrive. Please welcome Dr. Jean Asius.
Thank you so much, Caitlin, and good afternoon or good morning, depending on where you are in the world. I am extremely honored to be part of today's conversation, and I have a couple of slides, and it's really meant to be a conversation, and I'm going to kind of go through them. So if we can get to the next slide. I'm calling this really Built to Thrive in this environment where many of us and many of our communities are really feeling the weight, if you will, of a confluence of challenges that we must kind of get back to the root, and that is really remembering and reminding ourselves that we were created to thrive. I'm a big fan of Brian Stevenson, and Brian has a quote in Just Mercy that says that you cannot be an effective problem solver from a distance. There are nuances and details you will miss unless you actually get close. So what I'm hoping for in the next 10 minutes is for us to really get close. Whatever you're doing, I would like you to just kind of just take a deep pause and to kind of think about this conversation that we're about to have. Next slide. I think it's important to kind of start off with why is this so important to me? You see, back in March of 2020, my bonus mom was diagnosed with stage 4 metastatic cancer. And just a few short months later, she neared her final days. And I want to remind you that this was in 2020 around COVID with lockdowns in full effect. And unfortunately, we were not allowed to be with her as she took her final breaths. Thanks to some amazing nurses and the use of technology, in this particular case, FaceTime, I was able to see her face and she mine for one last time. She struggled to get out the words and sounds when she saw me, and I told her how much I loved her over and over and over again. As the machines beeped in the background and as her chest raised and lowered with the assistance of a ventilator, you see, she passed away a few days later, in fact, on her birthday. So, August 5th, 2020, I lost my bonus mom to metastatic breast cancer. What would I give to have just one more conversation with her? And it is in that moment that I realized time is absolutely everything. Think about it. Time is the only non-renewable resource. We can find ways to innovate. We can find ways to produce every other resource on this planet. But once time is spent, there is no getting it back. It's a finite resource with no substitutes or alternatives, which make time extremely vulnerable and expensive. So when we have this conversation around what the findings are, what I'd like you to think about is who's that family member, who's that neighbor, who's that coworker that you know of that, for better or for worse, has shortened their time. And think about what we might need to do to move forward together. Next slide. You see, in this country, there is what I refer to as a huge difference in life expectancy. You can have two neighborhoods that are less than 10 miles apart and have two totally differences in terms of life expectancy. In fact, it's about a 20-year difference in terms of life expectancy between two neighborhoods. So I like to say that premature death in many cases is not accidental, it's really a choice. That's in oftentimes in certain neighborhoods, shortened lives are clustered where investments are absent relative to longer lives where this actually flourishes. And you might be saying, well, Gene, what does this actually have to do with the discussion that we're having around um, the findings and trusts and how that is a barrier or a facilitator of actually getting access to services? And I'm going to kind of walk you through this. One of the things that was interesting to me in the study was the fact that 39% of individuals indicated that their experiences around mistreatment, whether it's because of discrimination or some form of it, impacted their ability to get the screening and the care that they actually needed. And that kind of gets back to my earlier point about time, and that is one thing we all have in common. Yet we know that where you live has huge implications for how long and how well you live, and trust is a social driver of health. Next slide. We also know that there's an economic cost to this, particularly when we look at community health and well-being across the country. We at CAC just released a major report, and the report found that 1.4 trillion gap in lost economic activity as a result of these differences in terms of community health and well-being. And that many employers, which are many organizations, health systems and the like, are absorbing those actual costs in terms of their bottom line. Next slide. And from a corporate standpoint, as part of this study, we've also seen that there's been a recalibration in terms of exactly what companies and corporations are investing in as relates to social impact. The red demonstrates that there's been a significant cut by nearly 60% in terms of funding to support healthcare access, 65% in terms of racial equity, 83% in terms of LGBTQ and equality. So as we kind of think about trust, and we think about services, and we think about partnerships, and we think about being able to ensure that every single person, regardless of their zip code, their background, their circumstance, actually has more time on this planet, we have to take into account the opportunities that we actually have in order to ensure that the broader ecosystem is actually meeting the needs of every single person, and in a way that actually recognizes and honor their sense of dignity, and equally important, their sense of humanity. Next slide. So trust. Trust, as I mentioned before, is a social driver of health. And one of the key things is the fact that how do we foster greater trust in an environment where there seems to be greater polarization? How do we get back to that level of proximity where people feel heard, they feel valued, they feel as if that their lived experience is accounted for and not dismissed? Next slide. So these are a couple of slides that I actually share with you from the Edelman Trust Barometer. It's a major study that is released every year. They've been doing it for nearly 25 plus years. And they actually looked at the role of trust in terms of health information. And what you find here is the fact that the role of trust, particularly in terms of media, has not recovered since pre-COVID levels. So it kind of gets back to what Jennifer was referring to in terms of there's greater skepticism, particularly in our society as relates to information. And what does that actually mean if people don't trust the information that they're receiving in order to actually activate the things that they need to activate in order to live a healthier, more productive life? And then equally important, how does that vary by different demographic groups? Next slide. As you see here is the fact that despite the fact that overall there's been a significant decline in trust in the broader healthcare ecosystem, my doctor remains one of the most trusted relative to scientists, in some cases relative to friends and family. And this kind of mirrors, I think, in many cases, some of the findings with regards to the report that the foundation just released. Next slide. I think this is extremely important in terms of exactly as we kind of think about the opportunities to ensure that people are receiving adequate information at a time and place that they need them so desperately, that we also understand what their hesitancies are with regards to the information that they need. And what you find here is the fact that across the globe, there is a significant distrust. More than 2/3 of individuals distrust. They say that I am hesitant or unwilling to trust someone who relies on different facts than me and trust different sources of information. So there is this opportunity for us to think about how do we reach people who are different from us and provide them with the information that they actually need in order to activate and get the services that they rightly deserve. Next slide. So I know that in this environment, the word equity has been polarized and for a variety of reasons. I'm sharing this with you because that I think it's critically important. AAMC actually did a report earlier this year that they released, and what they found was the fact that overall, when they looked at a national study of more than 5,000 individuals, there's great support for the term and the definition of health equity. More than 75% of people actually support the term. Let me rephrase that. More than 75% of individuals support the idea of what actually health equity is. When you actually use the term, what you find is that it actually drops by 10 percentage points. So overall, the key message here is the fact that there's broad consensus that people believe that everyone should have an equal opportunity and a just opportunity to attain the highest levels of their health. However, when you use certain terms and labels, that support might decline. Next slide. And you see this even in terms of by political ideology. I think this is extremely important in this environment, that what you find here is the fact that overall, whether you're liberal, moderate, or conservative, there's general support for ensuring that every single person has a fair and just opportunity to attain their highest level of health. So I just wanted to kind of just ensure that we kind of anchor that for the work that we need to do to ensure that people are actually getting the screenings, to ensure that preventive care is possible, and that we can ensure that people can have a much longer time on this planet, regardless of zip code. Next slide. And as I mentioned before, this right here shows you when we use the term health equity, how overall there's still general support. Next slide, please. So I want to kind of leave you with this, that you actually have the power. Next slide. You have the power, as many of us do, to ensure that every single person have an opportunity to live their healthiest life. And that is because of the fact that we all know someone, whether it's in our family, in our community, in our church, in our synagogue, wherever our house of worship is, in our work of place, um, that requires and needs the opportunity to live their healthiest life to the maximum as they see fit. Next slide. So just a little bit about CHC. Part of what we're doing here in partnership with the foundation and many other organizations, and hopefully with all of you, is to really understand how do we remove and address the barriers that impact people's ability to live a healthier life. We do that through our work with our nonprofit partners, our business partners, and of course, government to create bold and trusted programs. How do we ensure that whatever information we're providing, and I would challenge you with this as well, is trustworthy? To what extent do we know and measure whether or not the information and service that we're providing people, that they actually trust us? And what does that actually look like? Next slide. And then I will kind of close with this. As part of the work that we've been doing, we have something called our Community Readiness Matrix, where we work with many organizations, and we believe that partnership is the new form of currency. That in order for us to really meet the needs of individuals in all communities, we have to think about traditional and non-traditional partners, and that by creating wrapped around services that we can actually see better health outcomes as a result of these partnerships. And this is a great example. Next slide. We have something called our breast and cervical cancer initiative that we've actually been working on with Merck and in Georgia, where we focused on reducing the disparities that we actually see as relates to breast and cervical cancer. And the theory of change was the fact that if we could do this through partnerships and provide wraparound services, what would the long-term impact be? Next slide. And what we found was the fact that, and we can go to the next slide. What we found was the fact that clinical services increased significantly. Over a 18-month period, we saw that 1,724 clinical services were delivered. That's about 870 Pap smears, 854 clinical breast exams. We were able to link nearly 2,000 people to preventative diagnostic care, and 63 people received genetic testing. And as a result of these partnerships, our partnerships went from 19 to 90, really connecting people, whether that was with food or housing or transportation, in addition to what they actually needed. So as we think about the work that we need to do on the ground, as we think about this opportunity to really foster trust, part of that fostering trust is being courageous enough to be willing to get close. And part of being courageous enough to be willing to get close is to understand what is that lived experience for the individual when they live your hospital, when they leave your clinic, when they leave your interaction. To what extent do they feel equipped, empowered, and have the resources and the wrapped around services to really live a healthier, more productive life? And each and every one of us on this call have the opportunity to just pause, understand who we're serving, their lived experience, and how we can co-create the services and solutions that they need in order to thrive. So with that, I just want to thank you. I'm looking forward to the conversation, and I will turn it back to Caitlin.
Okay, thank you so much for that fantastic presentation. Let's dive into the questions. I have a couple here for you already. While the audience will put those questions in the chat, as a reminder, you want to click the More button and then pop those into the section that says Q&A. So, Dr. Asias, you've spent your entire career bringing together organizations across a bunch of different sectors to address health challenges. What have you learned about the role that trust plays in successful community partnerships?
Thank you so much for that question, Caitlin, and thank you all. I am really blown away. Kudos to everyone. We have over 231 people on this webinar. I'm extremely impressed and blown away by that. And I think that is how we actually start to really kind of close the trust deficit. I think key important elements in terms of partnerships that are vitally important is to what extent do we have shared goals, shared beliefs, shared values? And what I mean by that is the fact that if we can align on shared goals, shared beliefs, and shared values, that creates greater trust. And I think the other aspect of that too is understand exactly what do each partner bring to the table that the other partner does not have. So being able to really articulate the value proposition and the strength of the collaboration is critically important. I do want to make a distinction, Caitlin, is the fact that oftentimes we use the word collaboration as if it's synonymous with trust. I do not think they're the same thing. We can be in collaboration because we have shared interests, but that does not necessarily mean that there's shared trust.
No, such a good
Trust,
point.
I think, is critically important in terms of understanding exactly shared vision, shared mission, shared values. To what extent do we align on those? And then how do we ensure that we are equal partners in achieving those shared goals and outcomes? And I think that's critically important.
Yeah, thank you so much for that distinction there in the difference between collaboration and trust. Um, let's drill down a little bit further there. So many communities we know have experienced historical or ongoing reasons to distrust the healthcare system and healthcare institutions. What are some of the most effective strategies that you've seen organizations use to help rebuild that trust?
So I think there's a couple of things. One is to what extent are organizations approaching this from a position of humility? And it kind of gets back to my earlier point. How do we see communities? Do we see them as assets or do we see them as liabilities? Do we see them as something or a group to that's in need? Or do we see them as a community that is resilient? Language matters extremely, and it's extremely important. Communities will know whether or not you're trustworthy by how you actually treat them. Are you listening to them, actively listening to them? Or are you just checking a box? To what extent are you actually meeting communities where they are? Or are you, again, checking a box? Folks will know. And you can just think about your own interactions. I think the other aspect of this too is the fact that if we really want to ensure that we're closing the trust deficit with communities, particularly those who have been historically marginalized or minimized or discounted, I think it's extremely important as part of this, approaching this from a place of humility, is to also take the time to understand how do we ensure that we're compensating them for their lived experience. I always say that lived experience is a form of expertise. It's equivalent to a PhD or a master's. And to what extent, as part of your interventions and your programs, are you inviting the community to participate, or are they in the receiving end of a service? And that matters quite a bit. If they are invited in early on, you gain tremendous buy-in. The other piece of that too is the fact that you might learn some things that you might not have known early on. So one of the things that we've realized, whether it's the work that we've done in Georgia or the work that we've done in Cleveland or the work that we're doing in DC, is that that first element of engaging community is so critically important. Meaning the fact that we take the time to really do focus groups, to actively listen, and not listen to speak, but to actively listen to what they say they want and need. And then we co-create what that might look like. We also compensate them for their time. And when I say compensate for their time, what I'm referring to, it might be a $25 gift card. It might be a $50 gift card, whatever the case may be. But oftentimes, going back to my earlier point, there's an opportunity cost. If you're asking me to engage, that means I have to do something less in order to do this. So how are we ensuring that we're doing this in a way that's meaningful and very intentional? When I worked for the Centers for Medicare and Medicaid Services, and we were actually creating the Money Follows the Person rebalancing demonstration, we were intentional about ensuring that Medicaid beneficiaries were part of the design of the programs throughout the entire state. And how did we go about doing that was understand what are some of the barriers that might impact participation. That might be childcare. That might be transportation. That might be economic security because they are an hourly job. So if they have to take time off, that means that they're not actually getting paid. So we ensured that as part of our community engagement strategy, that we were providing stipends, that we were making things virtual, in person when needed, that we really kind of went through the process of saying, okay, how do we remove these barriers to really have full community participation? And equally important, that they feel as if and they know that they've been heard.
Yeah, thank you so much for that response. We do have a question in from Maui. Thank you for dialing in, by the way. In our most remote communities have the highest cancer rate. We have a shortage of PCPs and oncologists at critical levels. How do we start building investment? Oh, that's a tough one.
I think it's a combination of both policy and advocacy. I think the work, Caitlin, that you and the team is doing is critically important. I think that um, we have to really kind of think about our infrastructure from a workforce standpoint. And part of it, and in ensuring that there is a match, if you will, particularly with regards to where some of those significant prevalences are in terms of some of the significant disparities relative to where the workforce infrastructure is. I think that's one element. I also think that there's an opportunity, and this is just me putting on my long-term care hat, to kind of think outside the box in terms of exactly how do we start to create and partner in ways to kind of close that gap. And what might that actually look like? And is there a role for private industry to kind of help support some of that work as well? I don't think that in this environment that one sector can solve all of these in isolation. I do think that's going to require a multi-sector approach where there is public-private opportunities to really incentivize this moving forward in order to close the gaps. I think investments are going to be critically important. And I think that we have an opportunity, and as part of this community, to think about, and I always say that there's always a cost to inaction. There's always a cost to inaction. So whether there's a cost in terms of delay, deny, dismiss, that's going to show up more broadly to our overall economic prosperity as a country. So I want you to keep that in mind. Hence, as to why I shared that 1.4 trillion dollar number. That number represents cost of inaction in terms of community health on an annual basis. On an annual basis. So as we think about our policy efforts, as we think about our advocacy efforts, I would encourage all of us to think also about, as a data point, as a talking point, that there's a cost to indecision, and that in many cases, particularly in the healthcare system, what we're talking about here is reallocating dollars and not asking for more dollars. Because let's be truly honest, we spend more than any other industrialized country in the world, and our outcomes are not as great.
So true, so true. Okay, I think we have time for one final question, which would be a great question to give you. If you could give just one piece of advice to the advocates, the navigators, the community leaders, all joining us today, when it comes to building trust, what is the most important message there?
Stories matter. Stories matter. I think we're in an environment right now that we have to elevate the voices and faces of people across this country, and to connect it to what I referred to earlier today. It's not about life expectancy. It's about your loved one. It's about your neighbor, your daughter, your sister, your brother, who for a variety of reasons have interacted with a system that don't see them, don't hear them, don't trust them, or don't actually take what they have to say to heart. So, Caitlin, I think that was one of the key things, and it's probably one of the most simplest things that we can do, but it's also one of the hardest, is to get close. I think that if we take the time to really understand, to hear the experiences and the voices and the concerns of those who have often felt voiceless, who have also felt unseen or unheard, and then we actually elevate that in a way that actually drives systemic change, that is powerful. We can argue, debate data every time and assumptions behind a data point. However, it's very difficult to debate with someone who has lost someone, who has experienced grief, who is trying to create an environment so that their children, their great children, their great 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 grandchildren can actually thrive regardless of where they actually live. That is powerful. It's not philosophical. It's not being Pollyannish. I think that we have an opportunity to really kind of get back to community and to really understand at the end of the day, what do we want and how do we want to be treated, and how are we doing that for others? And I think that is the ultimate opportunity that we have before us, especially in this environment where there is a great sense of polarization. But if people feel as if that you hear them, that you see them, that you're treating them with a sense of dignity and respect, and that you're honoring their experiences, the good, the bad, and the ugly, I can assure you that that trust deficit would decline.
Wow, thank you so much, Dr. Asias. I would love to continue this conversation. You've been so wonderful. And we do have to move to our next speaker, but we might have time to come back for questions at the end. So Thank you so much. Our next speaker is Whitney Ann Henry, Patient Navigator Coordinator in the Department of Indigenous Cancer Health at Roswell Park Comprehensive Cancer Center. As a member of the Tuscarora Nation Deer Clan, Whitney brings deep expertise in patient navigation and community engagement, working to reduce barriers to screening and ensure patients feel supported throughout the cancer care continuum. Everyone, please welcome Whitney Ann.
Next slide. Thank you all for having me today. It's been a great honor to be a part of this workshop. So the name of my talk is Two-Row Wampum and Indigenous Patient Navigation, Building Respectful Parallels of Sovereignty Along the Cancer Care Continuum. So when I go through, I would like everyone to kind of keep in mind and listen to dates, times. It's more of a story I'm telling of how our navigation program came to be, as it's very different compared to other programs out there. So I started at Roswell Park in 2015. I'm an enrolled member of the Tuscarora Nation and just really wanted to, I had family experience with cancer, so it was just a way for me to give back to my community, and I just felt like it was a great position. So being in there, you realize there's different reservations and nations have their own forms of government, and it never really occurred to me until I was in my position that each nation has their own views of research and cancer. And so along the way, I've learned, how these nations, react to it, and, you don't want to go full force. So next slide. So the two-row, so you're going to hear this a little bit throughout. So what is the two-row wampum, and why does it have to do with patient navigation? So the two-row is the first symbolic agreement between Europeans and Native Americans when they came to the US. And we didn't have any formal written down agreements. The belt was the agreement. And it was to respect each other's ways of life, culture, and traditions, and still go about life together. So that's the two different rows. So one row would be our Native American traditions, way of life, and then the non-Native way. So we still have the same goal of wanting a cancer-free life and healthy lifestyle, but it's respecting each other's ways of life when you go throughout the process. Next slide. So from being at Roswell, so Roswell Park is located in Buffalo, New York, with probably 3 Native American reservations very close to the area, and I'm from the one that's close to Niagara Falls. And so we, from our point of view, we know patient navigation was needed, but we needed to, hear it from the community themselves, kind of explore what it looks like to get cancer care when you're a community member. How does that look? So we did a quality improvement project. So that's the two-row collaboration with Indian Health Service, rural partnerships, and the cancer care continuum. So a lot of our reservations are located in rural areas, and a lot of our communities go through the same thing, have the same barriers, and we felt it was, in line with two-row, the two-row wampum. Let's meet with these different communities. Let's hear them out. What does it look like to get cancer care? Is it hard? Like, where are these barriers? And so there's 4 different sites that we went through. So different Haudenosaunee communities in New York State. So upstate New York, close to the Canada border, and then downstate, kind of close to Pennsylvania border, way south of Buffalo, and then the rural communities around those areas. And each one of those sites explained that they needed cancer patient navigation, and that everyone in those organizations were filling the role of a navigator on top of their nurse, or if they're a provider, or if they're just, front desk staff. They're all playing that role of a navigator on top of their everyday duties. And I would get that from my home clinic. I kind of understood that, but I didn't realize how prevalent it was everywhere else. So with that, and concluding everything, we knew there was a huge, dire need for patient navigation, not just for our Indigenous communities, but also for our rural communities. Next slide, please. So that quality improvement project paved the way for our Indigenous and rural patient navigation program. And what's unique about this program is that we have 3 Indigenous sites and 3 rural sites. And the rural sites are federally qualified health centers that I think we mostly already had agreements with. So that wasn't too bad to get navigators in there, but we wanted to pair them with Indigenous navigators just because of where everyone, not everyone lives on territory. Some people live off territory. Some people go to, rural clinics versus one on the reservation. So we just wanted to be very inclusive of our communities. So luckily with the quality improvement project, we were able to get funding for a very large grant for our Indigenous and rural patient navigation program, which allowed us to have 6 navigators, so 3 rural and 3 in our Indigenous communities. So that was in 2021. So again, right now COVID is going on, and we're just working through it, and our team is expanding now because we have this awesome grant. And so with that, as I mentioned before, working with Indigenous communities, very important to be aware of their government system, whether they are traditional or if they have their own form of government. So I'm from the Tuscarora Nation, and we have chiefs and clan mothers that are council, and they are the leaders of the community. Where Seneca Nation, they have president and all the rest. They also have council, but so just we're an hour away, and we have different types of governments. So just being aware of that is very huge. And not all tribes or nations have the capacity to hold these programs. So you have to be very understanding and patient with the communities. So 3 of our navigators were able to get in clinics with the federally qualified health centers, but our Indigenous navigators were kind of like, what do we do? Because, the health systems on the reservations weren't really buying our program at the time. So we decided to go more community-based and just work at community outreach events to really hit the public. We weren't forcing anybody to go to Roswell. We really wanted people to get screened wherever they're at, to meet the community where they're at. So along with the COVID time, so we also, during this, we established our virtual patient navigation line, just keeping in mind that, everyone was still kind of like not really going to appointments, but, still need to stay up to date with their care. So it just allowed another avenue for folks to get help, or, if they had any questions regarding screening, they had access there. And so it took a couple of years. A lot of our Indigenous navigators just we found a little community office with an organization we may have worked with, just so we could be in the public and be visible to the community that, we're here to help. So eventually by 2024, this was a huge win for us, is that all of our Indigenous navigators were embedded in the reservation clinics. So we have one that is at Tuscarora, one that is with the Seneca Nation Health System, and then a navigator that's with the St. Regis Mohawk Health System in upstate New York. And that helps us, reach the patients more, kind of work with providers a little bit more if there's questions that patients might have regarding a screening. That's where the navigators can come into play, just answer those, frees up time for the provider. But it takes time. It's not something like, we know it's, this would be so much better if we could get in right away, but it takes time. It takes trust. They need to see you, to see your commitment. Next slide. So where does this mistrust come from? Why are our communities not wanting to talk to the doctor? Why don't they want to go to Buffalo to get treatment? Well, for Indigenous communities, the more recent one is the residential boarding schools, which I think the last one closed in maybe 95 or 96. So very, very recently. So this is very recent family history for some people. And we have Thomas Indian School, which is literally in Buffalo's backyard on the Cattaraugus Reservation, that many providers here at Roswell are not aware of. And you wonder why there's like, oh, I don't know if I trust my doctor. But this is very recent history for our folks. So just really understanding, having that understanding goes a really long way. And with that, it's just health in general. It goes, it's like a trickling effect that they don't, ooh, Roswell, ooh, I don't trust you. We would go tabling and they would see us with our Roswell blue tablecloth, and we would just get avoided when we actually have a program that's there to help people get screened. And social media now, there's so much misinformation out there. We want to make sure our community gets more accurate information, more novel information, and so that's what we're trying to get the program doing. Next slide. So listening to the community, as you can see this picture here, you see we have a blue tablecloth and then we have a purple tablecloth. You can also see the change from Center for Indigenous Cancer Research to, it's a little small, but Center for Indigenous Cancer Services. That was just us listening to the community, us seeing people avoid the Roswell blue, and not even coming to ask like what we're doing there. So we switched our colors to be more representative of Haudenosaunee community, so purple as in the wampum. And our navigation program is not related to research, and just being part of Roswell, that's just what the community thought that we had to do with. So we were able to change our little centered and add another wing to services. So our navigation program would fall under the services and not under research. And another thing with working with Indigenous communities is just listen to them. Too many times I feel people come to them with, oh, I have this project. I have this great project. Do you want to do it? And it's not really the opposite. So, listening to them, listening to their needs is huge. And also being transparent. There's a lot of the old research going on, the Havasupai study, like just not being transparent, and blood samples going off for other things. It's being transparent in what exactly you want to do and how you want to help is very, very vital. And then elected tribal governance, as I mentioned before, doesn't always follow the US cycle. So some nations are every 2 years, their cycle changes and the presidents change, and all of the different department staffing changes. So then you have to kind of go about and go reintroduce yourself, reintroduce your project or program, let them know what you're doing. So that's just something to be mindful of when trying to build trust, that it's not as much as we want it to be so fast, because the world nowadays, you get everything so instant. Working with Indigenous communities and other communities that have very similar barriers, it takes a lot of time, and showing up and being visible in the community is huge, and it goes a long way. For our director of our department is from the Seneca Nation, and he had to go to the council and present to council, as well as present to the health system board for our navigation program. And that didn't happen overnight. That took, it took a little bit. So I just want to, end with kind of, it takes a lot of time, and just being transparent with the community and being visible is where you're going to build that trust. And now our screening numbers are getting higher. So it takes time, but it's worth it. It's worth it for our communities. I'll give it back to you, Caitlin.
Thank you, Whitney, and thank you so much for that presentation. We do have time for just a couple questions. Can you talk a little bit about how patient navigators can help address barriers that go beyond maybe that clinical setting. I mean, we hear all these other social determinants of health, like transportation, finances, language, or family responsibilities.
Yes, so definitely we are like we are a resource for resources. So we are just constantly mingling and connecting with other local organizations. So we're just very aware of tribal organizations that are there for community members, and just like going to these health fairs, going to any opportunity where you see a new organization, and just sparking up a conversation and like, oh, I have patients that are going through this. Um, I think that's where I think that's a lot of it is just kind of just going out there and being there and just like, oh, what is your program? Because you have to they're coming to you for all this help and like for these resources. So our navigators have to be very on the know of like new and upcoming programs that are available. So just very being involved in the community, being aware of, I think smaller grassroots organizations are huge too. So just a lot of involvement and just putting yourself out there.
Absolutely. So that's a great dovetail into my next question. What skills or qualities would you say are the most important for navigators who are working with the communities who have experienced this distrust and maltreatment throughout the healthcare system?
The major one that comes to my mind just from this work is active listening, really listening to your patients. This is a lot that they're hearing. They have life-changing news and they feel like they haven't been heard, probably leading up to that diagnosis. So just really sitting down, taking the time, letting them just talk to you, and just being a really good active listener.
That's great. Well, thank you so much. As we move into our final presentation, we are so honored to welcome Mackenzie Weldon. Mackenzie brings a unique perspective as a healthcare professional, breast cancer survivor, and patient advocate. She offers insights shaped by both professional experience and lived experience, which we know is so important as we talk about this topic today. Her story underscores the critical role trust plays in helping people navigate prevention, screening, and care. Everyone, let's welcome Mackenzie.
Thank you, Caitlin. I appreciate the time today. I'm going to take you guys back a couple of years just to share my story with you, which I think out of what happened to me of becoming a cancer patient has really shaped the way I want to approach the healthcare industry in the future in my role as a professional, but also in my role as a human, partnering with friends, family, and anyone I can connect with that may be in a situation where they are affected by cancer themselves or have a loved one who is. I've worked in the healthcare industry for over 20 years, and I'll honestly say I thought I knew everything about the healthcare industry and my role in serving the community through finishes and services for healthcare end users. In July of 2024, I started my dream job with Shaw Industries and was going to continue on my role in supporting the healthcare industry. I was at that time about 5 months behind on my annual mammogram, and I had put it off for many of the reasons why the previous speaker spoke to: mistrust, fear, those sorts of things. In October of 2024, I finally had a mammogram and received the letter in the mail that nobody wants to receive. They found something, they'd like you to come in for a biopsy. Shortly thereafter, 4 days after my son's birthday, I was diagnosed with invasive ductal carcinoma. That was what I read in my chart. And as you know, in a lot of cases, if you engage in my chart that your health system provides you, you're getting all the data and test results in real time, but you're not always getting that upfront engagement from a human standpoint with a nurse navigator or a provider that can help start that process of where do we go from here? I've just been diagnosed with a major life-threatening disease. I have no idea what to do and what lays in front of me. And I did what everybody said I shouldn't do. I started to Google information. And through that process, I found a lot of resources for me that actually helped me take my fear and put it into action in actionable ways that would help me survive and thrive through this entire treatment process. And one of those things where I found preventcancer.org. I actually found someone who was connected to preventcancer.org that was actually staged with the same type of cancer, stage triple negative, stage 3B breast cancer, and was a thriving survivor. And that gave me a lot of comfort. And it helped through that navigation of getting those connections, whether it be through preventcancer.org or friends and family, or just Googling information about the provider that I was going to meet with in mid-November to be fully diagnosed and start a treatment program. It gave me such empowerment to know what I needed to do, the questions I needed to ask, and to take that fear and move it into action. So in November, I was officially staged with triple negative, stage 3B. I met with my oncology team and my nurse navigator probably about 2 weeks after my diagnosis. And at that time, I asked the question, why wasn't anyone talking to me in those first early days when you're getting this diagnosis in my chart? And the information they gave me was tremendously beneficial. That team sprung into action the minute they received my diagnosis and started to build a plan for me with not just one provider, but many providers through the health system I was leveraging. And it gave me incredible security throughout that process, knowing that I had that kind of support. I started treatment in early December. I had a really transparent doctor who gave me any and every type of information I could want or ask for to help me navigate neoadjunct chemotherapy. I had 16 rounds of it. I had 16 rounds of immunotherapy. And at that point, we bring ourselves into May. I had an MRI. They said that everything looked good. I was ready for surgery. I chose to have a double mastectomy as it would help provided a more long-term outcome of success for me, which was great. And I went into surgery and came out of it a few hours later, was told I was NED, so no evidence of disease. From that point on, I went into recovery, and that's where things got a little dicey for me. I was then launched into connecting with a radiation team. So I was introduced to a radiation oncologist who was really on the fence about whether or not I should be radiated traditionally because I had some activity inside my body with my intermammary nodes that lit up when I was first diagnosed under an MRI scan. Since that couldn't be biopsied, they assumed it possibly could have been cancer, and since it resolved itself through the chemotherapy treatment and immunotherapy treatment, it was a safe assumption that it was. And traditional radiation I wasn't a great candidate for that, but the doctor wouldn't put it in writing in my chart as to why he didn't recommend it. Instead, he kind of on the side suggested to me that I seek alternatives. And at that time, I left feeling a little unnerved because I had such a wonderful experience, throughout a traumatic first 6 months of my treatment. And now I'm entering a phase of where I don't feel like someone is helping me guide me through this process. So I started to navigate towards another alternative, which was proton beam radiation. And during that time, I was dealing with some side effects of my double mastectomy. Actually, gained an infection throughout after getting my double mastectomy, and I was still navigating that. And that started the lengthy process of me onboarding with a provider for proton beam radiation. I chose to go forward with proton beam radiation after careful consideration of that provider and discussion and recommendation from not only them, but then me advocating for myself and going back to my oncologist and back to other people in my network that were also working in the oncology health system to uncover, if that was really get validation that that was the right plan for me moving forward. During that process, though, I'm still fighting this infection. And I had to jump from considering when I would start radiation to treat this infection. And I was really in this stage of, I was in limbo because I was meeting with specialists from infectious disease. I was hospitalized and treated intravenously with drugs to try to manage the infection. And I wasn't getting the answers or the closure I needed to get approval from my radiation oncologist to move forward with radiation therapy. And at some point in that process, I finally had to say, okay, based on the evidence I've gained from oncology, radiation oncology, infectious disease, this infection's resolved itself and I need to move forward. I moved forward with 15 rounds of proton beam radiation therapy and had another little hiccup. But what I will say about that process is what I learned in that gap of time where I was being treated for my infection. And I was very uncomfortable because I didn't feel the providers were giving me the answers I needed that I was asking for, even if they knew confidently they couldn't answer them. And I had to navigate that throughout that process, which developed a little bit of mistrust. But as I worked myself through radiation and ended that period of my treatment, which ended in November of 2025, I received so much good care from all of my care team from my oncology team at the beginning of my treatment all the way to radiation oncology and transparency to the point where providers were calling me apologizing for what had happened to me, knowing that what was happening to me from a health standpoint was a rare occurrence, but they wanted to give me reassurance that they were listening, that I could trust them. And then they'd prove that trust with follow up and repeat appointments and things to get me to a place where I am today. I've just celebrated, we'll call my 6-month NED. I'm still in remission, but I'm really confident with the care that I have received over the last 2 years that I will stay cancer free and I will continue to advocate for my friends, my community members, my professional colleagues, whoever I can talk to about the importance of screening. And if you don't know where to start, go to preventcancer.org. They're a tremendous resource for you to get you connected to people that will help you through this, even if it just means getting past the fear of going to a screening.
Thank you so much, Mackenzie. I think we have time for one question and then we got to close, which is a great segue what you just said. So many people know that screening is important, but are still hesitant to schedule their appointments. From your perspective, what would you say? What are the fears, the concerns, and stands in the way, and how can you overcome those?
I think the biggest fear I had as a working mom is I don't have the time. And I was in between insurance because I was moving from one job to another. So there was the cost factor. There are so many resources though out there that I've learned that can help you through that, any types of situations like that shouldn't be a barrier. Now because of that, I'm ahead of schedule when it comes to all my other preventative screening. So I think unfortunately it took the shock and awe of my news of getting cancer to really realize how important it is to be ahead of the game when it comes to preventative screening in the future.
Thank you so much. And I love how you brought it full circle back to Jean's presentation about time, right? We can't get that back.
Mhm.
So with that, I'm going to close out today. We're grateful to our presenters for sharing their expertise and lived experience, to our sponsors for making today's conversation possible, and so much to each of you for joining us in this important conversation. Throughout today's workshop, we've explored a simple but powerful truth. Trust is not built through a single message or interaction. It is built over time through listening, transparency, consistency, and meaningful engagement with the communities we serve. As advocates, healthcare professionals, community leaders, and partners, each of us has an important role to play in helping people feel heard, respected, empowered to take action for their health. When trust grows, so does community and prevention for early detection and ultimately better outcomes. We encourage you to carry today's conversation back to your organization, your communities, and your networks. Continue asking questions, sharing what you've learned, and seeking opportunities to strengthen trust wherever you work. Together, we can create a future where every person has the confidence, information, and support they need to move forward from skepticism to screening. Thank you all so much for being part of this effort. We look forward to continuing the conversation with you and hope to see you again next year.